Can you hear me?
Yeah, we can hear you. Srinivas, carry on.
Thank you. Thank you very much for the organizers for allowing me to present online today. I'm in Bangalore, so thank you for that. Of course, I think I have been given a very challenging topic because proton therapy is not very well established in this context of stereotactic body radiation therapy. And I will try to do justice to this topic as much as possible. The reason why it is not established is because of inherent limitations of the proton therapy technology available so far. As we know that for extreme hypofractionation, which I like calling it as extreme hypofractionation rather than Sbrt, but nevertheless, that is a more popular term. But the requirements for a conventional photon-based Sbrt techniques is effective patient immobilization, precise target localization, treatment plan to ensure steep dose gradient, minimize uncertainties due to tumor motion and interplay effects, image guidance to ensure accurate treatment delivery, and motion management are very well established with conventional photon-based image-guided radiation therapy approaches. But they were not with proton beam therapy. First of all, the image guidance was not robust. Very recently, about 5 to 6 or 5 to 7 years back, image guidance is available as a routine on most proton therapy machines. There was a major issue with the treatment delivery without image guidance. Motion management technologies itself were not very well established. The algorithms which we have been using for last 10, 12 years, Monte Carlo step 3, type 3 algorithms, which are much more advanced for especially in lung cancer Sbrt situation, were not very well established with proton therapy. And the interplay effect, especially the tumor motion, especially in the context of tissue motion, transient deformation, and density variation, resulted in major issues in proton therapy when we especially do extreme hypofractionation. With fractionation, it is probably the best dose blurring thing which you can do, that is with fractionation. But when you have lesser number of fractions, these uncertainties get amplified. And this is just an example to show that this is a nominal based situation where if it is a static target, immobile target, then the coverage is like this. And when we give internal margins, which is what we give for conventional Sbrts, we generate, we do a 4D-CT, we generate an ITV, and based on ITV, usually it's very well established. But if you see with protons, ITV as a solution does not cover the problem of motion in protons, especially in pencil beam scanning proton beam therapy. And now we have situations where we are able to use tracking, either surface tracking or tumor tracking, or gating, which is essentially volume repainting, rescanning techniques, which are enabled now to address the motion in proton beam therapy. So there are several motion mitigation strategies available for spot scanning. As you can see, there is significant, if you do not apply these motion mitigation strategies, there is significant underdosage of the tumor. And there are, you can see that with several, I will not go into details, but I think the best type of motion mitigation strategy one could use is regating or rescanning, and is usually sufficient to achieve acceptable 4D plan quality close to static doses. We also had a limitation as far as the technology itself is concerned, the passive scattering. Although this was not in the context of Sbrt, we can see that there is a significant benefit with intensity modulated proton therapy compared to passive scattering, and majority of the literature which is coming from lung for both Sbrt as well as in stage 3 lung cancers is on passive scattering proton therapy. And this study actually elegantly showed that grade 3 cardiac toxicity and grade 3 pulmonary toxicities were significantly lower with intensity modulated radiotherapy. If you're not using IMPT, you're not strictly deriving the full potential of proton beam therapy for lung cancers. Also, analytical algorithms and Monte Carlo algorithms have been compared for protons, and specifically in the context of lung cancers, analytical algorithms tend to overestimate the dose and target by as much as 10 to 40% and underestimate the doses to 10 gray. So essentially the double trouble. So you are it should be opposite. It should be if we have to be more cautious, we want a system which can accurately estimate or even slightly overestimate the OR so that we are conservative, and in fact underestimate the doses to target so that we are again conservative on that aspect. But this is an article which was published in 2017 and which elegantly mentions that most proton therapy centers in the United States use treatment planning systems that employ a simple analytical algorithm for dose calculation. And this will make all the previous literature not very reliable and not very robust, especially in the context of today. And thereby you can see that now with modern or current generation proton therapy, you can see that there are ways to minimize uncertainties due to tumor motion. There is in fact ways to estimate the interplay effect as well on the modern treatment planning systems. Image guidance is now available as a standard. Motion management techniques are available and can be integrated with pencil beam scanning therapy techniques. This is our protocol as far as motion mitigation is concerned. We do a 4D CT. If motion is less than 5 millimeters, we go for free breathing treatment on protons. If the motion is more than 5 millimeters, we try for a deep inspiratory breath hold or a compression belt. If breath hold is reproducible and for more than 20 seconds at least, if not more, then the patient goes for the breath hold technique, irradiation, the breath hold technique. If not, the compression belt is used. And if with compression belt, if it is close to 8 millimeters, we can treat this patient on protons. Otherwise, we use conventional techniques. So to essentially conclude my first few slides, it is now feasible to deliver spot scanning protons for early stage lung cancers with extreme hypofractionation, the kind of fractionations which we have been routinely using for a long time. But essentially with Sbrt, the morning half also showed that the results are excellent for even majority of the tumors. So in that context, why and when should a proton Sbrt be used? One thing which comes to our mind clearly is in certain challenging areas, certain challenging patients, where the patients could have central or ultracentral tumors, where it could become challenging with conventional Sbrts. We know that several studies have shown reasonably high rates of grade 3 and grade 5 toxicities in these group of patients. Of course, we've learned to fractionate them, lower the doses, but if you strictly want to see in these patients, there is a definite amount of toxicity. Another challenging situation is when we have multiple tumors. When we have multiple tumors, again, this is the constraint for 5 fractions, 1500 cc or 1.5 liters with 12.5 gray or less, spared lung. And this is a constraint from RTOG trials. And sometimes this could also be a challenge when we are treating multiple tumors. And these are situations when we want some other technique to ensure that we are able to restrict our doses to the normal healthy structures. This is a Particle Therapy Cooperative Oncology Group consensus statement on proton therapy for early stage lung cancers. And the committee clearly recommends that for small peripheral tumors, there is absolutely no benefit using proton Sbrt, and there is no benefit over photon Sbrt and should not be used except in certain exceptional situations, such as in interstitial lung disease or in patients with prior RT. Large peripheral tumors could derive some clinical benefit. Select patients may benefit, dosimetric comparisons may help. But in patients who have central, ultracentral tumors, where challenging to limit to the doses to the constraints, tumors near brachial plexus, when we have multiple tumors, recurrent re-radiation setting, these are the patients where one could benefit. There are now multiple dosimetric studies which have shown that there could be sparing of aorta, brachial plexus, bronchial tree, esophagus, pulmonary vessels, heart could be spared better with proton beam therapy. Of course, this is from the era of the passive scattering proton therapy, not the full potential of proton beam therapy. Also, chest wall, there have been 2-3 studies at least showing significant dosimetric benefit as far as chest wall is concerned. in patients receiving proton beam therapy. Similarly, there was a multicentric in silico clinical trial which also compared conventional SBRT versus passive scattering proton therapy. Again, there is some benefit, but very modest benefit. As I said, this is not the true potential of what proton beam therapy plant can generate. There is a large retrospective nationwide study which actually included 669 patients with 682 patients, all treated with stereotactic body proton therapy. T1, T1B, T2A, the doses were very comparable to what we usually use for photons. Median follow-up of 38.2 months, and they showed very comparable results with what we usually see with photon SBRT, with much less toxicity. And this is the table they've compared between conventional SBRTs in Japan and other multi-institutional series, compared them to proton beam therapy, and you see the local progression-free survival and overall survival was are quite good, and the rates of pneumonitis was quite low in this group of patients. This is a national cancer. Thank you, sir. National Cancer Database analysis also showed that there could be some benefit with protons as far as overall survival as well as progression-free survival was concerned, as well as the toxicity was lower compared to grade 3 to grade 5 toxicity were lower in patients with SBPT compared to SBRT, of course, with all the limitations of National Cancer Database analysis. This is a phase 2 randomized trial between SBRT versus SBPT, but this was a passive scattering proton therapy. Unfortunately, the trial was prematurely closed, showed that limitations of doing a randomized trial in situations such as these. This is our experience so far. This is one of a 73-year-old reformed smoker with solitary pulmonary nodule, right lower lobe lesion, underwent lobectomy, poorly differentiated adenocarcinoma, then had a mediastinal recurrence, subcarinal recurrence, received chemo-RT for the same, and then had another right paratracheal nodal recurrence for which surgery was done. EGFR, ALK, ROS, PD-L1 were all negative. Right hilar recurrence after a particular time, and then this was our first patient of re-irradiation of central tumor, where we used proton therapy, and we used, of course, because it was the first patient, we were cautious and we used 16-15, and we could achieve excellent conformality, and we could spare the proximal bronchial tree to all the constraints. This is another patient who had extensive ILD. You can see on the PET, and there was a tumor, and there were a few nodes as well, and then all the nodes were negative, reactive, and we took this up for protons, and this is the patient, and this was a patient who was on 5 liters per minute oxygen while the continuously. The patient continues to be on 2 liters per minute. The oxygen requirement slightly come down. There is a complete response, and you can see that there is hardly any reaction around the tumor after proton beam therapy. Similarly, we have treated multiple tumors. You can see the multiple tumors here, and we have been able to treat these patients with SBRT. Of course, some of them are been also oligometastatic, where we had to treat for oligoprogression. And this is my conclusion slide, that small peripheral tumors, absolutely there is no indication for protons. In challenging situations, when we have large peripheral tumors or ultracentral tumors where achieving those constraints is very difficult, or tumors near brachial plexus, multiple tumors, recurrent re-radiation, in these situations, proton therapy could be utilized to deliver extremely hypofractionated radiation. Thank you so much.
Okay, thank you very much, Srinivas. Excellent talk, and of course, not much is known about proton's role in SBRT. Maybe just one quick question due to the paucity of time, or any comment from the audience. If none, then we move on to the next talk. Thank you very much, Srinivas, once again. Dr. Anupam Rishi from Florida, Moffitt Cancer Center, he'll join us now to talk about MR-guided lung SBRT.